So let's go on to the next speaker for the next free paper, which is Professor Bernardo Rappaport, a medical oncologist here from Johannesburg, private practice at the Medical Oncology Center in Rosebank and Linksfield Park Hospital. He was a lecturer at oncology at the University of Pretoria, and he has extensively published in peer-reviewed journals, and his talk is on dysregulation of immune checkpoint proteins in newly diagnosed early breast cancer patients undergoing neoadjuvant chemotherapy. Comparison between TNBC and non-TNBC patients. Please.
Thank you very much for the kind introduction. I presented a similar paper, but it's not the same at the SACO meeting like a week ago, you know. So here we were requested, we published this data at Frontiers in Oncology and Frontiers in Immunology, and we were requested specifically by two reviewers, two different ones, to do this analysis comparing triple negative versus non-triple negative, because according to them there would be a very big difference between the two. Anyway, so let's go. So the study, the aim of our study was to measure systemic levels of co-inhibitory and co-stimulatory immune checkpoints. It's similar to what the previous speaker was speaking about, PD-L1 and CTLA-4, at the time of diagnosis, following neoadjuvant chemotherapy, and post-surgery. And then we were looking at the differences between triple negative and non-triple negative patients. As a background, we know that breast cancer is associated with upregulation and downregulation of these immune checkpoints. Soluble forms of immune checkpoint, and I'm going to go into detail because when we do the histology, we look at one of the membrane ones and that's it. It can be measured in human plasma. And examples of this includes PD-L1, LAG3, and TIM3. And then we know that on the first steps of when we have the immune cycle, you get activation of the immune cells in order to, and they upregulate or downregulate these immune checkpoints in order to kill the cancer cell. And the immune response can vary depending on the levels of the immune checkpoints also. Now, this is what I wanted to mention. It's not restricted to CTLA-4 and PD-1 or PD-L1 here, as we can see. This is extensively researched, but now we're starting to look at in the clinic and looking at LAG3, and there's a variety of other immune checkpoints. And then it's also the activating immune checkpoints that in some cancers are depressed, while on the inhibitory checkpoints are upregulated, and it's a mechanism of immune evasion. The immune system doesn't recognize or doesn't see the malignancy because of this type of mechanism. Just to mention, for example, PD-L1 is also physiologically during pregnancy very upregulated so that the immune system doesn't attack the fetus. Now, this is very important also because it's a concept of immune surveillance and immunoediting, as we can see here. If you have, there are different soluble effects of the different immune checkpoints and different cytokines and chemokines at diagnosis and during equilibrium and during escape or immune escape, and you have immunosuppressive microenvironment during immune escape, while it's more antitumorogenic when you have, for example, on the elimination phase. And the cells that contribute to this includes immunosuppressive cells, as we can see here, which includes T regulatory cells, myeloid-derived suppressor cells, as well as, for example, we have the macrophages, so that means M2 macrophages or tumor-associated macrophages. Sorry. In addition to that, you have other cells that might be affected on the microenvironment. It's like immuno-excluded cytotoxic T cells, as well as you have in all the other cells, for example, such as like natural killer cells. Yeah. And this you can see here, the immune dysfunction here, that is part of the big problem. It's not related to only immune evasion because you upregulate or downregulate the PD-L1 or the CTLA-4. You have also the problems of the other soluble factors and also the immunosuppressive cells, as we can see here. Now, this is important because when we talk about the different factors associated with all this, we talk about the membrane PD-L1, that is the one that we say more than 1% or less than 1%, 1 to 49. There are various forms of PD-L1, which includes exosomal one. You can have a by RNA splicing also, as well as you have in the nuclear PD-L1, and those circulate in the blood and all are bioactive and they're very immunosuppressive. So the methods, we have an assay that we can do 70 immune checkpoints to measure by a multiplex bead arrays as well as ELISA methods. And then we prospectively collected here for this analysis 72 breast cancer patients and 45 healthy controls. And then we measure the different levels, and the different levels were measured by the Mann and Whitney test and by the Kruskal-Wallis at different points in time. And then we did Spearman correlations to look at the relationship between PD-L1 and the other immune checkpoints. And we can see here the p-value at 0.05 was taken as statistically significant. And then we use NCSS 11 to do the statistical analysis. And let me show you some of the results that are very interesting here. This is the patient characteristics. Basically, we have 52 patients with triple negative and 20 non-triple negative, and the majority were stage 2 and 3. Now, this is a PD-L1. We can see that if we have a pre-treatment, the PD-L1 level was depressed, but if you look at the differences between triple negative and non-triple negative, there were no significant levels differences at all here. Pre-treatment, post-treatment, post-surgery. Here we see that following treatment, both on the triple negative and non-triple negative, the levels of PD-L1 increased, in some instances up to 4-folds, but between the two subsets, there was no significant differences at all. The same applies for LAG3. LAG3, the levels were significant, they were 4-folds following chemotherapy, which we think is an immune regulatory mechanism to cause immune evasion also. You block one and the other one goes up, so you need to blockade more than the PD-L1 on these patients. Look at TIM3 is also like that, and there's no differences between the triple negative versus the non-triple negative patients. And this is another immune checkpoint that, in my opinion, will become important. It's not researched, it's under research, but it's not therapeutically used. It's HVM called. It's one of the negative immune checkpoints also. And this is some of the correlations that we've done also, looking on the, first of all, on the entire cohort between PD-L1 and LAG3, TIM3, and HVM. It's all positive correlations, but the most positive one is with LAG3. When we look at post-treatment, we got the same effect. If you look on the previous one, you can see the increase on the levels, and they all increase together as you have the R value, therefore the correlation is very high. It's almost near 1 with a very strong p-value, specifically for the LAG3. But you see the same effect with the other negative immune checkpoints. This is the correlation between the triple negative also, and you can see that it's very strong with the LAG3. This is also post-treatment with the triple negative. And finally, I'm going to show you non-triple negative with LAG3, very strong correlation also. And you have very, very strong correlation on the non-triple negative post-treatment. So the story that the immune checkpoints are only involved with triple negative breast cancer is not true. We can see here on this data very clearly showing that is a strong correlation with non-triple negative. Maybe the pembrolizumab, it doesn't work on that setting, or atezolizumab, but further treatment should be explored or maybe developed and so. Now here you have the patients with metastatic breast cancer. It's a different paper that we are busy writing up now. And you can see also that there are enormous levels of TIM3 and LAG3 on this, as we mentioned before, equilibrium, or like elimination, equilibrium, and immunoscape. Patients with metastatic breast cancer, like in green, they have very high levels of LAG3 and TIM3, which supports the theory of the immunoscape here. So what we can say in conclusion, that we demonstrated before low levels of co-stimulatory and co-inhibitory molecules on patients with newly diagnosed non-metastatic breast cancer. Novel findings on this study includes the following: treatment with neoadjuvant therapy, you get a substantial increase of the immune checkpoints, especially the negative or the inhibitory immune checkpoints. We believe that this is like an immunoscape mechanism, that if you block one, the other one will go up and the cell will continue functioning and you will continue with immune evasion. And we also found that there is no significant differences between triple negative and non-triple negative patients, that the immune system is involved not only on the triple negative, but in all the patients with breast cancer. And future research looking at combination approaches from the diagnostic, prognostic, and also therapeutic point of view is warranted on patients with breast cancer. Thank you very much. I got it on time, maybe.
Do we have any questions from the floor?
Yeah.
Yeah.
Thanks very much, Prof. Just two quick questions. How did you choose your time points of assay? So post-treatment, was there anything particular that guided you? When did you do them?
We was not arbitrary taken at completion of it. We could do it every cycle also, but I mean, it's expensive to do that. So we did pre-treatment and we did at the end of the neoadjuvant treatment. And then we wanted to see if the effect of surgery was also there, altering the immune system. So we did pre-treatment, post-neoadjuvant chemotherapy after 6 cycles, and post-surgery. And the interesting part is that all the effects were seen between pre and post-treatment, and there was nothing on all the 17 immune checkpoints on the patients after surgery. Surgery had no effect on this research at all, yeah.
Just because sometimes these things happen quite quickly and at different time points, and it might be quite interesting to see if we missed something in that regard. And secondly, did you correlate clinical outcomes with this at all?
Yeah, we done it, and there was no significant. We done it. It's not correlation with PCR, but the study is ongoing, and we need to see on time to progression and overall survival. For interest in time, I didn't go into the detail of that. We done that. We put that on the publications on the frontiers, specifically because one of the aims of the study was to see if you could measure it in the blood, immune checkpoints, and to see if it correlate with PCR, yes or no, and also to go with response to treatment on the non-triple negative patients. But we haven't find that at all. And also, we're looking. The patients are being followed up to see time to progression and overall survival. Yeah.
There's another question, Gil.
Yeah, Dr. Tawane, yeah.
Thank you very much, Bernardo. As always, very interesting, very thought-provoking. So in the end, how do you, and I'm asking much for myself and for the audience, how do you anticipate that this work is going to affect how we think about immunotherapy in early stage and metastatic breast cancer? When we walk away, how do you anticipate that this research would shape how we approach treatment with immunotherapy in breast cancer?
Look, at the moment you get only 20% like a benefit with immunotherapy in most of the studies in breast cancer, especially in the triple negative neoadjuvant. I believe, looking at this, that it's not one immune checkpoint, it's more than that, and if you combine more than one antibody, it's going to be very effective. You see, you need to get more than one blockade, because if you look at the whole microenvironment and what we call it now macro environment, it's the systemic effects also, the cells. We're looking at having an assay looking at different cells by flow cytometry also in the immunosuppressive cells in the blood also, not around the tumor. So we believe that you need more than just giving a little bit of anti-PD-L1. You need much more than that. So you can see that when you give the antibody alone, it does with some effect. If you give antibody with chemotherapy, you have better effect, but you might need to blockade to understand better which ones are the hierarchy of this. And to me, all the data that we've done, and we've been working on this for 5 years when people were not talking about this, we see that the LAG3 is very important, and we're working now on studies looking at LAG3 on patients with metastatic melanoma. There is a patient that I recently treated that we gave the combination of both, and the whole cancer disappeared in one shot. So I think it's going to move forward this on the combination treatments of different immune checkpoints. One thing that we haven't done, look, we have 10 minutes here. We have also on the assay 8 of the co-stimulatory ones, and those co-stimulatory ones are depressed also. So they are doing studies now looking at OX40 and CD137 and so on, that you might be able to not increase the activity of the cytotoxic or CD28 also, not only by blockading the inhibitory ones, but stimulating the co-stimulatory ones, and the cells become more important. In addition to that, there might be other branches of the immune system that might be important to target. For example, the natural killer cells, like CD16 and CD56. I haven't shown anything, we're working on that. We don't have final results, but we're working on that. But we think that the natural killer cells also kill the cancer. So the research has been done at the moment is just on one thing: CTLA4 and PD-L1 and cytotoxic T cells. And it's a whole myriad of things that probably will, in the 10 years' time, will be targeted for sure, yeah.
Thanks a lot for that.
Thank you very much.